Dr. K. Srinivasan, consultant interventional cardiologist from Apollo Main Hospital, Chennai, speaking on hypertension and its guidelines. Hypertension is a silent killer, and as we know that in Geneva 2011, WHO various reasons for mortality throughout the world, it has been shown that hypertension is the leading cause of mortality among the other risk factors. Yes, we know that the global burden of hypertension is going on increasing, and by 2025, it has been estimated that 30% of the world population is going to be hypertensive. And that is also reflected in India also, and in our way, hypertension incidence is increasing. And what is important is it is not the mere hypertension diagnosis that is important. Even after diagnosis, we have to start the treatment. And after starting the treatment, we have to make sure that blood pressure is under control. Because it has been found in our country that diagnosis of hypertension happens in about 1/3 of cases. And of that, 1/3 only getting treated, and that 1/3 only is getting controlled. So indirectly, it means that out of the total hypertensive patients, only 15% are getting blood pressure controlled. Remaining 85%, even though they are getting the blood pressure diagnosed and started treatment, but it is not under control. That means we are not justified in treating this hypertension to its optimum level to prevent the hypertensive complications. So what happens is, when you take both systolic and diastolic blood pressure together, 27.3% of patients only under control in India. Balance patients are not under control. So, in other words, almost 70% of our patients with hypertension are uncontrolled despite being on treatment. So, it becomes more important not only to diagnose, to start the treatment and call the patients for regular reviews and check the blood pressure and up-titrate the medications or go for combinations and make it optimum in order to get the blood pressure to its expected goal. And when we consider the hypertension, as we know that we have guidelines, both American guidelines and European guidelines, and it has been clearly said that stage 1 hypertension, stage 2 hypertension, and above. So when you go for any hypertension above stage 1, then straight away the recommendation says that go for dual drug, that is double drug. The advantage of going for double drug or triple drug is that with small doses, so when we go for multiple drugs in a given patient, then we could be able to control the blood pressure with small doses, so that we'll be able to control the blood pressure better. At the same time, the side effects of the individual drug also will be less. So it becomes, double advantages in that we'll have a better control of blood pressure and with less side effects. And the same double drugs or triple drugs, if it made into a single pill, that is single pill with multiple drugs, then the complaints increases, the cost comes down. So we will have multiple advantages when we go for multiple drugs in a single pill. So that is where the guidelines has come into the evoke, and it has been said that when you have hypertension with a background of ischemic heart disease, then which one will be the first drug of choice? So if we see, generally ACE inhibitor or angiotensin receptor blockers that comes in the top of the antihypertensive armamentarium. The second drug will be calcium channel blocker. And if patient has ischemic heart disease, then it becomes second drug will be beta blocker. So beta blocker with ACE inhibitor or ARB, beta blocker with calcium channel blocker, beta blocker with diuretics. So that will be the combination which we will go for hypertension management in a patient who has ischemic heart disease with hypertension to start with. Then if blood pressure is not under control, you can add the third drug, which may be any one of the other two. So like beta blocker, ACE inhibitor, diuretic, beta blocker, ACE inhibitor, or calcium channel blocker, or beta blocker, calcium channel blocker, diuretic. So like that, we can go for combination. And when more than 3 drugs is necessary in order to get the blood pressure and control the so-called resistant hypertension, then of course we can go for alpha blocker and of course the centrally acting drugs like that. If same hypertensive patient comes with say chronic kidney disease, then the drug of choice starts with ACE inhibitor, ARB will be the first choice. Second choice will be calcium channel blocker. Third choice will be a diuretic. Depending upon the GFR, the diuretic will be decided. Like GFR is low, you have to go for loop diuretics. Then comes the beta blocker as a fourth drug when it is BP still high. So beta blockers comes in the first choice of drug in an antihypertensive management when the patient has a heart failure, or patient has ischemic heart disease, whether it is acute or chronic, or patient has an atrial fibrillation, or patient who is young lady who is likely to become pregnant. Then such cases, the beta blocker comes in the top. Otherwise, ACE inhibitors, AR, ARB plus calcium channel blockers, then diuretics, then only beta blockers comes. So that we have to remember when we choose the medication. Then regarding the other indications, if we see in the management of hypertension, when we consider resistant hypertension, so when there is that is the need for fourth drug is there, or the control of blood pressure is not to the optimum level with three drugs to the maximum tolerated dose, then we call it as resistant hypertension. So whenever we consider resistant hypertension, we have to make sure that before we labeling a patient as resistant hypertension, we have to rule out pseudo-resistant hypertension. So what I mean by pseudo-resistant hypertension, you make sure that patient properly takes the medicine, where patient is not skipping the medicine, or patient is not underdosing the medication, or patient is not over salting. That is, he is taking too much of salt, or a patient has associated problems like patient may be having morbid obesity, he may be with sleep apnea, or he may be having renal artery stenosis, or he may be overtensed personality, type A personality, and other endocrine problems. So we have to rule out a lot of secondary causes for likely hypertension before we are labeling a patient as resistant hypertension. So with the background of whatever I've told, so to conclude, a fixed dose antihypertensive combination medication, what are the advantages we are going to have when we go for a fixed dose multiple drugs antihypertensive combination medications? Will have synergistic effect of targeting different mechanism, will have preserved efficacy or enhanced efficacy, and will have increased medication adherence, and it will be very convenient for the patient at less cost, and patient also will be more compliant, and the safety goes up when you use less dose of multiple drugs, so the side effects comes down. And another thing is you add ARB with calcium channel blocker like amlodipine and telmisartan. The telmisartan takes care of the pedal effect, side effect of amlodipine. So one side effect of one medication will be nullified with the other drugs. So multiple advantages we'll have when we go for fixed dose multiple drugs combination. So with that, I'll conclude the talk. So hypertension, it is important to diagnose, not only to diagnose, to make sure that we start the treatment and we control the hypertension. That is more important. So call the patient regularly and follow up and adjust the medication. We should not be shy out by just continuing the same medication, thinking that patient might think the doctor is adjusting again and again like that. We have to make sure that we have to adjust the medication to the maximum in order to get the BP under optimum level. Then only we'll be getting the full benefit of controlling the blood pressure in preventing ischemic heart disease, stroke, and death. Thank you.